Then your slides, guys, then go on to talk about malaligned teeth. So malaligned teeth, ladies and gentlemen, are basically teeth that are not in their correct positioning or are not correctly aligned into the dental arc, be it in the maxilla, in the mandible, or in both. Okay, so the first type of grouping of malaligned teeth is crowding. So they talk about how crowding is the most common contributor to malocclusion. One or many teeth can be involved in this misplacement. Normally with crowding, so crowding, ladies and gentlemen, sometimes occurs, or most of the time occurs, when the jaw basically cannot accommodate all the teeth that are in the arc. Okay, so either the jaw is too small or the teeth are too big. One of the two tends to be the issue here. This is normally common, especially with anterior teeth, either in the maxilla or in the mandible. Okay, and then normally with crowding, then basically the teeth are basically all skew. So crowding can either be caused by either one tooth or a group of teeth, as your slide basically describes. We then also go on to overjet. So overjet, they talk about an excessive protrusion of the maxillary incisors that causes space or distance between the facial surface of the mandibular incisors and the lingual surface of the maxillary incisors. Yo, that sounds like a mouthful. Basically, ladies and gentlemen, overjet is the horizontal relationship between your maxillary teeth as well as your mandibular teeth. Okay, so yeah, you see, so that horizontal relationship, so with the palatal surface of our maxillary teeth as well as with the facial or the buccal surface of your mandibular teeth, that horizontal relationship is known as overjet. So overjet is, we normally, like in a class 1 relationship, a patient should have an overjet of about 2 millimeters. More than that is then deemed to be an excessive overjet, which we will then have to correct orthodontically. So that's basically what this little paragraph is explaining to you guys, that horizontal relationship between your maxillary and mandibular teeth. From there, they talk about an overbite. So an overbite with the malaligned teeth, they talk about an increased vertical overlap of the maxillary incisors occurring. So basically, ladies and gentlemen, overbite is the vertical. You see, with overjet, we're talking about the horizontal relationship. With overbite, we are then talking about the vertical relationship that your maxillary teeth has with your mandibular teeth. So how can I put this? How much space the maxillary teeth covers on top of your mandibular teeth. So that is basically the vertical relationship. Is that making sense? So yes, we do have instances with overbite. So an excessive overbite is when basically the maxillary teeth cover a large space, maybe let's say more than 2 millimeters, or large vertical relationship relative to the mandibular incisors. Does that make sense? I really hope it does. And then from there, they talk about an open bite. So an open bite is a lack of vertical overlap of the maxillary incisors and creates an opening of the anterior teeth when occluded. So basically, guys, these are the patients that when an open bite is basically when the maxillary incisors do not overlap onto the mandibular incisors. Does that make sense? So this would be a patient that comes in, and then when you ask them to bite, in front it will look like this. Does that make sense? That is basically an overbite. This. Nah? Yeah. So if you ask a patient to bite and they have an open space in the anterior aspect of their arcs, that is then known as an overbite. Okay, and then from there we have a crossbite. So a crossbite is a tooth or even a group of teeth, ladies and gentlemen, that is not properly aligned with its opposing tooth. Okay, so now crossbite is basically when your teeth have a reverse relationship. Okay, so we know, guys, when a person bites, that the maxillary teeth are going to occlude on top or anterior to our mandibular teeth. Look at me. That is how we know a person to bite. Né? So now in a crossbite, it is basically when the maxillary teeth then occlude on the lingual aspect of our mandibular teeth. So when you ask the person to bite, they'll look like this. Okay, I can't do it. Let me put in a picture. There we go. Can you guys see that? Great. So that is a crossbite. A crossbite, ladies and gentlemen, can happen either anteriorly in the arc or even posteriorly. So that's when we then go as far as then, yes, you have a crossbite. Is this crossbite anteriorly or is it posteriorly? So that's what we wanna then know. So then benefits of treatment, they talk about psychosocial. So psychosocial, obviously, guys, you can imagine if you have discrepancies either with your teeth or with your jaw, it can really affect one's self-esteem, especially in children. Children are mean, and you'll find kids that then become, you know, antisocial. They keep to themselves. They have depression, all because of how they do not like or despise their facial appearance. Okay, so basically psychosocially, we're talking about how orthodontics can be used to actually improve teeth, therefore improve the patient's facial appearance, and therefore improve how they interact with other people, as well as their self-awareness and self-esteem. So obviously, if you feel better, you're going to interact with people better, and your life will generally improve. So that's the first benefit of treatment. And then oral function, obviously improving oral function, we're talking about the ability to clean. So you can imagine, guys, if someone has crowded teeth and they brush their teeth, they can't get all that plaque out. Then sometimes this leads to calculus and recession and mobile teeth and having to extract teeth and all of these other problems. So just the ability to clean their mouth better, take care of themselves better, you know, less trauma, because sometimes if teeth aren't allowed, if they aren't aligning properly, they can cause damage to other teeth as well as the soft tissue in the oral cavity. Okay, and then from there, improving dental disease. So now we're talking about, like I'm telling you guys, if a patient's teeth are aligned properly, they can clean their teeth properly, they can take care of themselves properly, and therefore we then increase or decrease rather the incidence of dental disease in that patient as well as in the population in general. Okay, so then we then go on to the management of problems. So with management of problems, here they then discuss the 3 types of orthodontics that we have. This is very important, ladies and gentlemen. So one, we have preventative orthodontics. Now, so here they talk about preventative orthodontics being to prevent or eliminate irregularities and malpositions in the developing dentofacial region. So this, I would say, we normally do with our young patients, let's say from 2 to 5, 6-ish. So we're basically just monitoring that they are, you know, coming for their dental checkups. We are filling teeth, you know, like as in doing actual restorations, because actually having carious teeth can in and of itself cause malaligned teeth or malpositioning of teeth, because now another tooth, let's say distal to that carious tooth, can actually get into that space, or teeth can then start rotating as a result of carious teeth. Okay, so we are basically just trying to monitor, promote oral hygiene instructions as well as education. We're making sure that everything is where it's supposed to be. If we are extracting teeth, we want to maintain those spaces. We want to keep teeth in for as long as humanly possible. So that's basically what happens with preventative orthodontics. Then from there we have interceptive orthodontics. So here we try to intercede or correct problems as they are developing. So now these are with our patients, let's say from age 6 to 12 or 13. So now they're relatively young, they're still growing, but we can identify that there are problems that are developing either within their ox or on a skeletal level, you see. So now we try to just, by intercepting, we try to correct that problem or minimize the degree of that problem before it becomes very worse, so that if should the patient then require let's say fixed orthodontics known as braces, right, then the problem will not be as severe as had we just left it as it was. So now here we're talking, for example, with our space maintainers, let's say kids who extracted teeth when they were younger. So now obviously that space, if we do not maintain that space, teeth distal to it can actually drift into that space and then cause space problems for permanent teeth that have to erupt into the oral cavity. Even with our class 2 and class 3 patients, we can actually even place appliances that actually try to restrict the growth of either the maxilla and the mandible, so that the malocclusion is not so severe as it would have been had we just not intercepted. So with interceptive orthodontics, even cross bites, you know, that tooth relationship, yes, we can actually use appliances to just kick that tooth out and place it in its correct positioning. So that's basically what we try to achieve with interceptive orthodontics. I could say treat minor problems before they become severe Okay, so that's essentially what we're doing with interceptive orthodontics. And then from there we have corrective orthodontics. So these are conditions that require the movement of teeth and the correction of malocclusion and malformations. So now, if let's say like with our growing patients, our class 2 and class 3 patients, let's say the maxilla is excessive or the mandible is excessive, that's then when, for example, they'll go for orthognathic surgery, for example, just to bring or to correct those both of those jaws, as well as then actually moving teeth. Okay, so that's where we now rotate teeth, we then create space, we then close certain spaces. So this, with braces, we can actually bring about a multitude of movements that can actually correct the alignment as well as the positioning of teeth in the dental arc. So that's basically what gets done with corrective orthodontics. We then go on to records as well as treatment planning. Ortho, guys, is very meticulous. So if you work in an orthodontic practice or with a dentist that does quite a lot of ortho, you guys are going to need to be very meticulous about your paperwork. So this is now very important. Now, so the medical history as well as the dental history are taken, as with all the other patients that we've discussed before. So I think you guys know that, and I'm not going to touch on that. And then from there, physical growth evaluation. So this is normally done with our x-rays, such as our PANs, sometimes CBCTs, depending on the institution, just to evaluate the patient's growth. And then from there, social and behavioral evaluation. Now, sometimes, like we said, ladies and gentlemen, some malformations or malalignments are caused by patient's behavior. So now a mother will be coming in, they're concerned that, hey, my child's teeth are skew, or we have an open bite. And then once you start actually evaluating the patient's habits, once they're not in your practice, you'll find out that maybe your patient is like a thumb sucker or a digit sucker. So now we know what we need to treat. Or sometimes, like for example, with patients that are like thumb suckers, you'll find that the patient has underlying psychological issues. Maybe they're not confident, or there's problems at home, so now they're basically just sucking just to, you know, deal with all the stresses that maybe they deal with at home or at school. So now such patients, not only do you want to treat the dental problem, you'll actually even encourage the mother to maybe seek out psychologists to actually go to the underlying cause, the main cause of the habits that you guys see in the dental chair. So those are basically some of the things that we have to evaluate with the patient. And then as well, our clinical examination, as you guys know very well. So then with records and treatment planning, they talk about an interview. So you talk to the patient in the chair, what they're here for, some of their habits back home. You then also even include the mother or the guardian to also get that adult perspective of what is happening with the child. And then from there, we then do our clinical examination. So normally we do normal charting that we do with all our other patients, as well as then in orthodontic practices, we then have an orthodontic examination sheet. So then we then check the patient's growth, we then check for any malformations, deviations, early loss of space, if there's any space available, if we've lost any space, the facial structure, the growth structure, the patient's facial form, and things to that effect. Okay, then from there we then evaluate records, or actually make records. So firstly would then be photographs. Photographs are very important in ortho. One, to have treatment planning, as well as then to protect you guys from litigation. Do you understand what I'm saying? So with ortho patients, obviously you'll then take profile pictures, you'll take profile pictures, frontal pictures, three-quarter pictures, where we can actually see the inferior border of the mandible, so that we can judge for the patient's growth. So those are some of the photos that I'm talking about. We also take intraoral pictures as with the patient occluding, as well as with the patient positioning anteriorly, so that we can actually evaluate what's happening dentally. Then from there we take radiographs. These are normally periapical, as well as our pan x-rays, and then from there even our cephalograms, so our cephs, just to evaluate the patient's growth, which will then obviously have an impact on our treatment planning. So then from there we'll talk about the cephalometric analysis. So we basically use anatomical landmarks of the patient's structure to then see how the patient is growing, analyze how the patient is growing, and then incorporate that into our treatment plan. We will discuss this at a later stage as we go along. Okay, then from there we have our diagnostic casts, also known as study models. So we take impressions and then from there making use of our impressions then to actually see how the patient bites, that basically the relationship of the maxilla as well as the maxillary teeth with the mandibular teeth. So that's basically what we then use our study models for. And then from there, financial arrangements, because you need to keep in mind dental or orthodontic procedures are very expensive. So actually, before we even go that far, before we even take all these x-rays, we would have explained to the parents, based on our clinical examination, what we see, what we think sort of will be the treatment plan. Then from there we'll give them obviously how much it costs, and then we can make the necessary financial arrangements should they consent to the treatment that you guys have suggested.